But if you can't get it, you can't get it. So I'll take quercetin EGCG, but however, with the caveat that you must use it in the right time frame, because once there are two diseases here. There's the viral infection, and then the immune response or over-response, which leads to the release of inflammatory agents, cytokines, and also things that cause blood clots. And we need to intervene and prevent that from happening. Because once someone has infarcted lungs or acute respiratory distress syndrome or pneumonias that are out of control, they're dead. So the key is not to get to that point. So EGCG and quercetin are extremely good for prophylaxis, and they're extremely good for mild to moderate patients for symptom relief, and they're better than nothing in severely ill patients.
And why do you need the vitamin C and the bioflavonoids with the quercetin? What's the synergy there?
So there's a paper I saw, I'm not an expert in it, but they found the data shows that the vitamin C activates quercetin to be a zinc ionophore. It's a cofactor. So it seems to work better with it.
Okay. And what type of doses? A few hundred milligrams?
I use 1,000 milligrams. Yeah.
1,000
By the way, it's water soluble. The more you give, you just make expensive urine. So it gets wasted, most of it. So as long as you get between 1,000 and 2,000 of vitamin C, it's more than enough.
Yeah, there's alternative ways to do that too. You can use liposomal C, and you also obviously parenteral or intravenous C. So, which probably is a different mechanism than.
But keep in mind, I'm looking for outpatient treatments.
Yeah.
IV. I'm looking to keep people out of hospitals. So, and logistically, when it needs to be scalable. This is very important. Mm-hmm. Now, I'm not against monoclonal antibodies or convalescent plasma or IL-6 inhibitors. It's fine. But it's not scalable. Not scalable in terms of logistics and cost. Mm-hmm. When we have a large population of people that need to be treated, it has to be oral, cheap, safe, and effective. And that's what, by the way, this is not new. This information was known in 2005, even before. There are papers with Fauci's name on it, calling it a miracle drug. Fauci called hydroxychloroquine a vaccine. There's a paper in which he called it an absolute dream treatment and vaccine. So it's conveniently forgotten, but that's what it is. It's a matter of scientific record.
Interesting. So if a patient, well, I guess maybe you can tell us your experience applying this protocol. Have any patients failed to respond and required hospitalization? And of those that perhaps did have to go to the hospital, what percentage passed away from?
So obviously, I'm going to speak directly about my team's experience.
Yes.
And nothing in life is 100%. I've never seen anything in medicine always work. So with that said, the high-risk population in this country has a 7.5% mortality rate. Again, those are patients over the age of 45 with medical problems and/or medical problems. So obviously, the older you are, the higher the percentage rate. So like in nursing homes, it's between 10 and 20%. Unless you live in New York in March or April, it was 50% or more. But obviously, the older, sicker you are, the more at risk you are. But if you group together all comers, the high-risk category has a 7.5% mortality rate. The first wave, I'm going to comment on the first wave, my team treated 3,000 patients. Now, let me define treatment because everyone confuses this. When I see someone and I assess them and I tell them, you're going to be okay, go home and drink fluids, that is a treatment. You have to know when to treat with medication and when not to treat, when to cut and when not to cut. That's assessment and judgment, medical judgment. A surgeon that only cuts all the time is not a surgeon. So out of those 3,000 patients, I only gave my 3-drug regimen to 1,000 patients. And 2,000 of them, I said, you're in the low-risk category, go home, you'll be fine. 100% of those 2,000 survived. Out of the 1,000 high-risk patients, which had an expected death rate of 7.5%, you would have expected 75 dead people, and a multiple of that hospitalized. I had 3 patients die.
Wow. Impressive.
So, you know,
what percentage of those required hospitalization? And did once they entered the hospital, were you in any way responsible for the therapy, or was that assigned off to a hospitalist?
well, I work with hospitalists, so we're like a team. So I am, the way medicine has evolved lately, it's you have outpatient and inpatient. It's rare to find a doctor that has a busy practice and dances in both places.
Yeah.
So I think it's okay. And I have very good colleagues that I've almost 2 decades have developed rapport with. So there's a good continuity of care, I would say. So there was a total of 15 admissions. 3 died. 4 were besides those 3, 4 were intubated, but they were all extubated and did well. And the rest were admitted for IV antibiotics for pneumonia, and they all did well as well. So basically, out of 1,000 high-risk patients, where statistically you would have expected 75 dead people, let's say 5%, 50 dead people, or 2.5%, 25 dead people. I only had 3 dead.
Yeah, 0.3%.
You cannot ignore that. That is, that's not even counting the risk stratification patients, which I chose not to treat. In other words, I was able to tell these patients, I know you're going to be fine, go home, you'll be fine. And that has value. So if you include those, the mortality rate is even less.
Mm-hmm.
So, and this has been reproduced. You don't have to listen to me. You don't have to call it, you can call it anecdotal all you want. But there are now Harvard professors of virology with 4,000 patient experiences. Dr. George Fareed, for example, or Dr. Harvey Reish from MD PhD from Yale School of Epidemiology, who has done his work and shown that it's absolutely statistically proven that hydroxychloroquine used in the pre-hospital setting is absolutely effective. It's impossible for it to be statistically, what the numbers show, a mistake. Dr. Peter McCullough, the head of cardiology and internal medicine at Baylor, amongst many other world-renowned and prominent physicians who are actually treating patients, who are in the empathy of care, the circle of care, who are not sitting behind a desk making theoretical decisions on life and death without having to tell patients or their families, I'm sorry, your mother just died for no good reason. So the people that actually care for human beings see the truth, and we're trying to communicate this to the American public because your government is not looking out in your best interests. So that means, there's a Second Amendment, the right to bear arms, is for one specific reason, that if there's a tyrannical government, that the citizens of the country could defend themselves against a tyrannical government. So I'm calling for a medical Second Amendment where if the government is tyrannical and they're preventing life-saving information and medications, that each person in this country is responsible for their healthcare and that of their families, have to be preemptive and get the life-saving medications which are available over the counter into your house, and be ready to treat if something happens, or even take prophylaxis if you fall into the high-risk category. Mm-hmm. That is my recommendation. I was on Twitter, and by the way, I had zero media experience before March. I was a quiet doctor who was taking care of his patients, and I was living a serene life. And all of a sudden, this all exploded on me, and COVID-19 chose me. I didn't choose it, And I, by the way, don't take any credit for this. I really do believe that this was a gift from God. He put this idea in my head, and all I'm doing is just trying to share that idea with other people because I saw it works. And I believe in the sanctity of life. I believe that every person is made in the image of God, and it's not my job to decide who lives or dies. So my job is to try to prolong and preserve life and reduce suffering as much as I can. I'm a doctor. That's my job. So that's the tragedy here. So I was on Twitter. I was getting 10 million impressions per tweet, and they shut me down last month for platform manipulation. I'm not even sure what that means. But I was honored to shut me down before the president. I guess they
Yeah.
continued.
There you
And
go.
so I had to develop my own website, and that website's free, and it has my protocols in like 20 different languages.
What's the name of the website?
It's my name, Vladimir Zelenko, MD.com. Vladimir Zelenko, MD.com. And it has all the protocols for prophylaxis and for treatment, has all the studies that document the rationale for it. So doctors could use it because it's geared for the layman and also for the researcher and academic physician, has patient testimonials, and it has access to telemedicine that a company like Speak with an MD that could overnight you medication. So if you live in a state that's tyrannical, you can have a consultation. If the doctor feels, I had to develop this because there were patients around the country who didn't have access. So I got together with some forward-thinking people and created a system. I don't get any, I'm not involved with it except for lecturing to them, but I'm just telling you that if you need medication, all you could do is schedule a consultation. If they feel it's necessary, the doctor of your state will then order it and the pharmacy will overnight it for you. It's a way to beat the system.
Is the availability of hydroxychloroquine improved, or is it still okay? So is it available to most everyone in the United States now?
Yes, but you have to. Well, if you have a doctor able to willing to prescribe it, and sometimes you have pharmacies that get in the way, so you have to go to another pharmacy. Yeah. It may take some diligence, but none of my patients go without the medication. If you put that.
And for those who aren't your patients directly, they can go to your website and find clinicians who are doing this consulting.
Correct.
Okay, perfect. So I'm wondering what your experience has been with the long hauler syndrome and what percentage of the patients you've seen develop this. And perhaps, I suspect if they intervene early as you recommend with your protocol, that the likelihood of developing this decreases quite dramatically.
Okay. I have 0 patients that are long haulers.
That's quite dramatic.
With the caveat, if they came and received treatment within the first 5 days.
Wow.
I have patients that are long haulers, but they came to me after that window and they were already advanced in the inflammatory process. So at that point, the cytokine storm had already taken hold. They developed blood clots. Some of them had pulmonary infarcts or strokes, actually. Others developed ARDS or catastrophic lung damage and pneumonias. And others just are not themselves. I don't know how to describe it, but it ate away part of their souls. They're not the same people. There's depression. There's lack of energy. There's a psychological impact as well. So it's not that I don't deal with long haulers, I do, but if the way to prevent the long hauler syndrome is to intervene within the first 5 days with appropriate antiviral medication in high-risk patients, and that is 100% successful.
Wow. Congratulations. That's phenomenal. So with respect to some of the details of your protocol, you had mentioned the anticoagulants because that's clearly an issue, but I'm wondering how effective you found NAC. This seems to serve a similar purpose as opposed to the anticoagulants.
No comment. I've never used it.
Okay. Interesting. And
it's not that I'm against it. It's just how it evolved. It wasn't, I'm going to look into it. I look into everything, by the way, but
MedCrem has been advocating that, which is, what catalyzed your interest in this to begin with, I think, or at least was a catalyst initially. Wow. I mean, this is really quite an impressive pieces of information that you're sharing with us. So, I meant to ask you initially what the details of your clinical practice. So it sounds like you're not a solo clinician, that you work with a team of other physicians.
Well, it's a multidisciplinary group that I built.
Okay. Oh, so you built the group. You're the founder.
Yeah. So I've had some personal issues that my career has changed a bit. 3 years ago, I was diagnosed with pulmonary artery sarcoma.
Whoa.
And they thought it was a saddle pulmonary embolism. And then when it didn't respond to anticoagulation, I started having coughing up blood.